Good afternoon. I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those who don't know the PCC, we're a national organization that convenes stakeholders from across the healthcare landscape who are committed to improving the nation's health by strengthening primary care. And I'm thrilled to welcome you today to today's discussion, diving into the experiences of early adopters of advanced primary care management codes. That's a bundled payment for primary care, and we're going to learn all about it and learn from those who have put it in place. A few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording and slides will be posted on our website, thepcc.org, within 48 hours. You can find all of our previous webinars on the site. We'll be taking questions using the Zoom's Q&A tool, usually at the bottom of your screen, and panelists will answer questions at the end. Please feel free to send in questions throughout the entire conversation. Chat's been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar. We're really committed to delivering high-quality webinars exploring important topics to the primary care community, and we'd appreciate if you take a minute or two to fill out the webinar survey after the webinar, so we can ensure we're meeting that standard. Before we kick off, we've got a surprise guest we'd like to welcome. It's my immense pleasure to welcome Dr. Jake Quinton. He's Chief Medical Officer for Medicare Parts A and B. And as part of this leadership team at the Center for Medicare, he works to improve the value and quality of care for Medicare beneficiaries. He focuses on traditional or original Medicare. He's also a primary care internist with an interest in increasing value, access, and equity in U.S. healthcare. Jake has limited time today, so we're only going to ask him a few questions to kick us off before we transition to our panel. But you can ask Jake questions by putting it into the Q&A chat at the bottom. We're going to follow up with him and do a video conversation and broadcast that later. So please, if you've got questions for Jake, put them into the chat. Now let me turn to Jake. First, Jake, from your vantage point, can you please describe APCM for our viewers?
Sure. Thank you so much, Anne, for having me. It's really wonderful to be back with the PCC. Certainly in this case, a surprise guest only because there's a critical internal briefing that will keep me from being here the entire time, but always excited to be speaking with the PCC and the primary care community. From our perspective at CMS, advanced primary care management really is an important step forward in our historic efforts to value primary care as it's delivered. And so when we think about primary care payment adequacy, we're recognizing that there's been a series of care management codes that have been developed over the last decade plus that and advanced primary care management is the next iteration in what we really consider to be the future of primary care. And it's really important to us to understand where it's working, where it's not working. And if we think about what services are primary care clinicians already delivering that we are capturing in this new coding mechanism, as you described as a bundled payment, there's some internal CMS folks that might call it a primary care global period. But we really are thinking about the next iteration of prospective payment for primary care service delivery. And as we said in the physician fee schedule, as we finalized it last year, that we believe primary care is the cornerstone of a high-functioning healthcare system.
Super. And this code has evolved over the course of the 2025 and 2026 Medicare physician fee schedule. Can you talk a little bit about that and what prompted that evolution?
Absolutely. So we, as a first step, we're identifying what are the core features of care management activities, what are the essential elements, and recognizing that as we're making this a more streamlined and prospective payment for primary care, we wanted to identify what are those core features, then also say, the specific counting of minutes is really seems to be unnecessary burden when we're really trying to streamline primary care payment delivery. That evolution that you speak of, I think in particular, we recognize the importance of the integrated behavioral health services, and we created, CMS does, we do love our add-on codes, and we put an add-on code for behavioral health integration, recognizing that 30% or more of behavioral service delivery occur, or 30% of primary care visits are behavioral health focused, and typically true for my clinic as well, and wanting to support that from a payment perspective.
Super. I don't know if you've done this calculation, but I know that this code covers things that maybe were inadequately paid for, that already existed, had existing codes, and some things that were never paid for that primary care has long done on behalf of their patients. Do you have any sense of what the mix is between codes that were already paid for and are now incorporated, and those that were perhaps never paid for it, but that primary care provided those services regardless?
That's a fascinating question, and I think it hits on a core feature of our overall Center for Medicare strategy. We deeply believe in the importance of adequately resourcing physicians for the work that they do, and we recognize that what we call internally is payment distortions, sort of sometimes where the previous survey methodology for identifying evaluation for services missed the mark and was inadequate. There's also times when it was overly generous, and we find that some physician services are overly valued in the fee schedule. And as we kind of right size those payments, we're recognizing that there are some services that have never been captured. Most of those have to do with the rapid evolution of technology in primary care and elsewhere. And so we're looking to identify as we go forward, and we may have more questions for PCC and others, what are those services that remain uncaptured even now? It's hard for me to give an exact number on the percentage as I think back into the individual care elements, but I think the commitment is to continue to evolve these advanced primary care management codes as technology-enabled care is that transitions primary care in ways that have even been transformative in the last 5 years of my own practice.
Super. Well, I mean, this can sometimes seem like a very arcane conversation about codes and payment models and all of that, but it can have real implications for primary care clinicians and patients. And we're going to be hearing from folks who are going to relay some of that information. But I guess from the CMS perspective, what are you hoping that this will engender for primary care clinicians and for patients?
From our perspective, we took a strong stance in the fee schedule with the development of the APCM care management or code family. And so we can say the arcane sort of, is this an evaluation management visit? Is this care management? Sort of what and how? What we're really trying to say is CMS believes that primary care payment should be not just at the visit itself when you see your doctor, but there should be some longitudinal payment for the in-between visit care. We really care to make sure that your clinician is able to check their messages between visits, to make those phone calls later at night, to coordinate your care with the many specialists that you see. And so what APCM allows for is the flexibility for that payment without having your clinician write to CMS every single time they check their patient portal or answer a telephone call. And so what we're trying to facilitate is this is the model of primary care that we all want at CMS for our aunts, uncles, and grandparents that are, or potential spouses and ourselves that are current Medicare beneficiaries. And so recognizing the importance for this, for the coding flexibility associated with this model of care. That's what we're really striving for. And I'll say what I'm really hoping to get out of this conversation, and I'll review it afterwards, is where has this worked? Who has kind of taken this first step? Because what we hear so frequently is that there's concern on an audibility perspective. We think we've been very clear about sort of what's included in these services and how it can be measured. But if there's more clarification needed, that's important for us. And then also, we've tried to be very candid about that we think this is a first step in developing primary care, or evolving primary care payment adequacy. And so as we go forward, we're trying to understand where do we need to provide that additional clarification and guidance for people to take it up.
Super. And what about from the Medicare beneficiaries perspective? What do you think this code might enable?
Really what we're thinking is that it's going to be getting back to the way medicine probably was practiced when they were younger. And so being able to access their clinical team, getting to have timely responses, and really it's supporting their clinicians in having somebody that's fundamentally looking after them. And so that care relationship we try to engender throughout all of our payment policy that you saw us write very clearly about in sorry to use another code term, the G2211, that complexity associated with longitudinal relationships in primary care. All of this really matters in terms of developing the reason we all do this, which is to make sure that that you feel cared for in the payment system.
Super. Jake, not having to record every single thing that you do, whether it's an email in the portal, a phone call, other activities, I think is welcome by primary care. There's a whole lot of conversation about administrative burden. So I'm wondering if you could reflect on that and how this code, might help in that regard.
Sure. Yeah, I might have to jump in just a second, but absolutely,
Yeah.
with regard to the administrative burden, we acknowledge that as we've sought to adequately resource primary care, oftentimes we're adding in additional code, and there's additional requirements to bill every single one of those codes, and we may be sort of penny wise and pound foolish in the sense that we are adding on more and more requirements to myself and other primary care clinicians that are making the work unsustainable. And so we know there's an epidemic of clinician burnout in this country. We know there's the more and more clinicians are leaving practice, and we're looking to put a line in the sand and say we believe that these are the services of primary care that happen across the board, whether they're captured and coding your payment system or not.
Well, thank you so much for joining us. And I know you had to carve some time away from the meeting you're supposed to be in. So we'll let you get back to it. And we'll be following up with the questions that folks have submitted. And we look forward to your response. So thanks so much, Jake.
Thank you very much. We want to know how to make this better. We want to make sure this is working for everyone that could be delivering advanced primary care services. Very curious on how to improve. We'll review the webinar in full and looking forward to hearing the success stories as well. Thanks so much.
Great. Bye. Okay, well, that was wonderful to have Jake visit us briefly. And now I'm going to welcome our panelists who will turn on their cameras and join us. So first off, I wanted to introduce Christina Buchetti, who's Vice President of Health Security at AARP in the Public Policy Institute. And in this role, she leads a team of senior health policy professionals to deliver research and analysis that drives and supports the public policy priorities, advocacy efforts, issue campaigns, and communication activities that advance AARP's really important work on behalf of older adults. Christina, great to see you, and thanks so much for joining us. Next up is Dr. Sam Hyatt. He is a clinical pharmacist with a background in community pharmacy, ACO and value-based care operations, and Medicare care management. He currently serves as the Director of Medicare Program Operations at Community Care of North Carolina, where he has built and launched an advanced primary care management partnership program to provide care management for the Medicare and Medicare Advantage populations at primary care practices across the state of North Carolina. Welcome, Sam. Great to have you.
Thank you so much.
And last but not least, Dr. Jason Lofton. He is a family medicine physician in DeQueen, Arkansas. Note, we have two Southerners today on our webinar. And has over 20 years of experience in the medical field. He graduated from the University of Arkansas for Medical Sciences College of Medicine in 2004, and he's affiliated with medical facilities such as Christ US, St. Michael Health System, and Howard Memorial Hospital. Lovely to have you, Jason.
Glad to be here.
It's great. I think we've got the right set of folks here to really help us understand a little bit about the early adopters of APCM and what we hope for, what we're seeing, and what challenges we're facing. So, Christina, I'd love to start with you. Jake explained a little bit about the APCM program and about what Medicare is trying to achieve with this bundled payment. If we saw wider adoption of this code, what do you think it might mean for people on Medicare?
Well, I'll say first, thanks for hosting this webinar, and I'm happy to be here. I'd say when you're asking what does this mean for patients, that I'd start by saying that, at AARP we learn a lot about what's important to older adults. And we survey them, and we know that they're concerned about how chronic conditions affect their health, their function, and they really do want to live as independently as they can as they age. And so we consider that they also tell us they're taking proactive steps to live independently, and we think that these kinds of advanced practice and care coordination really help patients partner with their primary care provider when the practices are equipped with the staff and the infrastructure that can monitor and coordinate their care, particularly outside of the office. And I think that's what you're getting to here. So when that's happening, the patients, I think, can have more trust in the practice working with them, and more confidence in their care. And I also want to make a special point to say that that this kind of good coordination and communication is important for patients and family caregivers, who really often have a lot of the burden of coordinating care for patients that are, particularly when they're sicker and they really have a lot of the chronic conditions. So I think those are important pieces.
Right. So I think what you're underscoring is that it's the patient, but it can be the network of people around that patient who might have questions, and want to connect. And just think about the web of folks then that primary care may be interacting with, which gets complicated and takes up time. And I think we all have this experience of going to primary care and feeling like I didn't have enough time. So I think, the intent here also is to try to provide some financial support for these kinds of activities so that you actually have the payment platform that can enable more time with the primary care clinician, which often seems in short supply. Okay. Anyone else would like to comment on this first question about, what it might mean for patients from any interactions that you've had?
I can go. So I found that some of my patients felt that they were bothering me on the weekend. So I have a texting system where my patients can text our main number. And so it comes across our computers, it goes to my phone, and because with APCM, what I told my patients is that I'm getting paid to kind of be available. I've always been available after hours. I'm finally feel like I'm getting paid for it. And it gave some of these patients, it felt like it removed the barrier that they weren't bothering me because they know I was getting paid for something. And so, on the weekends, I try to call in, if there's a bladder infection, I tell my patients I can save maybe $1,000 ER visit by calling in a $4 medicine. And it helps them understand why we're trying to do this, that we're trying to improve care and lower cost, and that I feel like it removed a barrier for some people feeling like they were bothering me. And I told them it bothered me when they went to the ER for something I could simply treat over the phone. And so that's what I have. I feel like more people are actually using this my availability after hours by explaining why I'm finally getting paid.
So they must have had a sense that you're super busy, and really you're so pressed to be able to have that kind of time. Would that be accurate?
Yeah, it is, and I mean I'm very grateful that Dr. Quentin and all they're doing, because it is, it's a struggle in primary care to financially to keep the doors open, so to speak, and this is a big help, and I hope they continue to look at this and continue to help us out in that way. But yeah, I think the patients realize that they know we're busy. They don't abuse the system, And I think some of them should probably call more than they do, but it has avoided some ER visits, which is what we do this for.
Sure. So now let me turn to the clinician experience, unless Sam, you wanted to add anything to
No,
that.
I just reiterate what everyone else has said. I think, for us, we utilize a care team as an extension of the provider. And I think we all know the provider's time is a very finite resource, especially in the current economics of our healthcare system. And so for the patient, just having a dedicated point of contact outside of their provider, who can route their questions appropriately or handle that question as needed. Because a lot of times it's non-clinical questions that come up during these conversations. And so, we can offload that from the provider's already very, very heavy work list. We've seen real value and real trust building with the patients through that work.
So I think you're making an additional point, which is it is the primary care clinician, but it's also members of the primary care clinician's team that might be responding to a question. And now there's more support for members of the team to take up those duties. And I think, every primary care practice is a little different, so it depends upon what the composition is. And you're in a very interesting position, Sam, because Community Care of North Carolina is a clinically integrated network. So you deal with so many different practice types across all payers, and you're providing a suite of services to help enable those practices to be successful and to participate in programs like APCM. Yeah, super. Okay, well, now let's think about it from the primary care clinician standpoint. I think what we've heard is that it could be a helpful tool for building out teams and infrastructure. Love to hear, both pluses and minuses of APCM in terms of the primary care clinician, the practice, the members of the team. And why don't we start first with you, Jason? And if you could just briefly describe the kind of practice you lead, I think that would also be very helpful.
Okay, so I'm a solo practice private family physician in Southwest Arkansas. Have approximately 500 Medicare patients, a mix of Medicare Advantage, Medicare, traditional Medicare. We treat all of our patients the same, regardless whether they have insurance or not, from the standpoint of what answering calls after hours. I'm in an ACO, and did CPC and CPC Plus from the early days because I do believe in where we're heading, and I want to spend more time with my patients. I think patients want to spend more time with their providers, and this is the first step in allowing us to get that extra financial resource to help us do that. So my team, I have a staff that a mix of MAs and front office, and everybody's monitoring our messaging service. And patients, we really encourage patients to use it. We obviously take phone calls, but we do spend a lot of time online doing PAs, and that just can tie up a phone line in a small practice like mine. And so those messages come across, and we can do refills. We can, call back and schedule an appointment quickly. And so our patients, are more and more realizing that they can get an answer quicker just by using our messaging service, but also after hours. So from a primary care, the provider standpoint, I appreciate, again, what it's doing to help us financially. If I wanted to see a change, I saw some questions about the cost share. Patients do not like to pay for a service when they weren't there that day. I try to explain it like insurance. If we all have insurance for cars or our house, everything, and it feels like it's a waste when we don't use it. But then when we have that accident, then we're glad we had insurance. And so that's the biggest gripe we get from patients is the cost share, and other providers. We all would wish that would go away.
Thank you so much. And I think we've heard that anecdotally, and there's a little bit of survey data that supports that this beneficiary cost sharing is really not welcome, I would say. And, you've got to set up your whole practice, right, to make sure that, those that don't have Medigap, they are tapped to pay for that that copay, which is 20% of the APCM service payment. And I can imagine it's very confusing to patients because they're used to a visit-based payment. They have a visit, there's the copay. But if on a given month, maybe there was no reason to have an interaction, you're still getting that monthly payment because the next month you may be spending twice as long as you would have, the month before. So, that is just the nature of people's care. And, I think the hope is that this monthly population-based payment affords that kind of flexibility with the ebb and flow of needs. But it is probably quite confusing to patients that they're being asked to pay when they haven't seen you that month.
Yeah. We've had a few that accused us of fraud, and we had to explain it, and say, hey, this is something Medicare themselves, Medicare started this. They want us to use this. And so, it takes some education, but our patients now understand it. When they use this, when they call us after hours, they're appreciative that we're available, which again, I tell them we've always been available, but it just helps us.
Sure. Well, I'm just going to say this very briefly, and you're going to be hearing more about this. The PCC is going to be doing our 2026 evidence report on APCM, and we're examining this whole beneficiary copay and what the cost would be if that payment was waived, because we do see it as a real impediment to the adoption of APCM. And so we'll be talking about this some more, but I'm glad that you raised it. Sam, any perspective you'd like to add here?
No, I 100% agree with the cost share barrier. We've identified many patients that would benefit from these services that just cannot afford that monthly cost share. And it may be modest, but still, that when you're on a fixed income, that can be a lot of money and that can be a hard decision to make. So I think when we're thinking about reducing overall cost of care with this population and the importance of longitudinal care management, access to care, removing those barriers is just critically important. And that's just one barrier that is preventing patients that could participate and would benefit from participation from, getting those services provided.
And I'll add that the cost is more for those with more chronic conditions. And
Yes.
so, those people usually have more other out-of-pocket services too. And so it really kind of adds up. I can understand the rationale for more, but it's really hitting people when they're already probably spending a lot. So I think that is one thing that we want to watch too. So I'll be interested in your report, Anne.
Super. And I don't think APCM is alone, but it is a little bit different that there is this monthly payment regardless of whether or not there's a service. But we also know from the literature that other add-on codes, like the Collaborative Care Code or the Care Coordination Code, where there is a beneficiary copay, that's also been an impediment to further adoption. So this is not a new problem. CMS knows that it's an issue. In fact, in their Medicare physician fee schedule, they asked for ideas about how to solve for this. And I think one thing that they're determining is whether or not it's within the CMS authority to address this, or whether or not there needed to be some legislation, legislative fix. So anyway, I think it is a recognized challenge. Just before we turn to Dr. Hyatt to provide some data about what they've been able to discern early on in this program, anything else in terms of benefits to the primary care clinician that you want to put on the table, or challenges? Just want to make sure we really have the chance to explore this further. So that's, anybody who wants to answer.
I know for me, it was easy to implement compared to something such as CCM, because we didn't have to do all the I didn't need a program to get started and to document the time tracking and I like it that we can verbally consent patients. So I did most of mine on my annual wellness visits. I would consent them, create their care plans. We'd update those, as we see the patients. And it was easily to implement for somebody that's looking for how do I get this started. That made it easier to have that verbal and versus say if you had a patient you could call and just explain what it is, we could get that started. So I appreciate the ease that it was easy to get started.
Well, that's terrific. And you obviously are someone who doesn't shy away from participation in these CMMI models. So you've been down that road. And I know that you participated in ACO, and I think you also have a relationship with Aledade. Did you get any outside help to help you set up the APCM program, or did you just kind of dive in on your own?
There was a short window of introduction. I think in November, maybe is when in 24 is when they released information, and really nobody had a lot of. Alade's really, really good about helping us with. I was just on a call yesterday. We're looking at the new Access program, and they're very good about helping get information to us. But there was not much information when we started, and so I took what was out there and we ran with it, and we're able to set up. We monitor stuff, with the internal or kind of an internal spreadsheet to keep track. I think one of the harder things to keep track of is when somebody has a transitional care management visit. We're not supposed to bill the same month, and you have to be careful on that because if you don't tell the biller not to bill the APCM code, then it can get billed, and you have to get back with Medicare. So that's another one of those little things I'd say, yeah, it would be nice to fix that just because it doesn't apply to everybody, but it makes it a little more challenging with those visits to make sure you remember to tell the billing team, don't bill this month when we have that TCM.
Super. Okay, turning now to you, Sam. Given how Community Care of North Carolina works across Medicare, Medicaid, and commercial to support independent and safety net primary care. Just explain a little bit more how CCNC supports primary care practices and how you rolled the APCM out and what you've seen since you did that.
Yeah, absolutely. And again, thank you for letting us talk about this because I think it's so important for our Medicare population. So Community Care of North Carolina, like you said, clinically integrated network across the state of North Carolina supporting independent primary care. A lot of rural practices, a lot of safety net practices, RHCs and FQHCs. And so historically, we've worked primarily in the Medicaid space. And so North Carolina has the Advanced Medical Home Payment Model that provides payment for Medicaid care management. Our practices, we have a mixture of pediatric and family medicine, internal medicine practices across the network. And we really wanted to be able to provide a more robust care management across all lines of business for a practice. So when they're thinking about an extension of their practice and how we can support them, they don't need to think about, oh, is this a Medicaid patient? Is this a commercial patient? Is this a Medicare patient? They know we can provide these services to them and provide them resources to help facilitate these services, really dedicated to these programs. And so when APCM came around in late 2024, launching January 1st of 2025, it kind of coincided with that very nicely that we could now fund, being able to provide these services to the practices. So what we built was a partnership program. So we use a care team model. So we use pharmacists, nurses, and medical assistants that work in coordination under the supervision of the PCP to provide that longitudinal management and post-utilization follow-up for these patients. And for our practices, like I said, many are rural, but even for our larger practices, it can be very hard to invest the resources required, to fund the technology. I know Jason mentioned kind of the technology component, and also, being able to fund a pharmacist and a nurse and these extra resources really focus entirely on these programs and making sure that these patients are outreached asynchronously between visits to make sure that what the doctor told them at their visit, they're actually following through on and doing, and they are actually getting that referral and getting that appointment with the specialist or whatever the case may be. And so, for us, it was how can we provide clinical resources to the Medicare Advantage population? And then how can we also financially support our practices as well for that work that they're doing? And so we build our partnership model so that the practice has to invest zero. And so they don't need to fund anything. We facilitate all of the required resources. But on our fee split, our fee schedule with the practice, we really just want to fund our resources at a bare minimum. We can spread that out across multiple practices, so it's much more feasible to incorporate these clinical resources. And so, whereas they may not have been able to provide these services to these patients before, now they can, and they don't need to worry about any upfront costs or any changes to their workflows or anything like that. We can just integrate with them and make sure it's handled on their behalf. So it's been exciting. It's been a lot of learning opportunities over the last year. We launched April of 2025, and so just crossed the year threshold. And it's been exciting to see the progress that we've made and the patients that we've enrolled in. As a pharmacist, it's nice to read the notes and see the impact, whether it's clinical or non-clinical. I'm sure Dr. Lofton can speak to this. We see a lot of barriers to care, SDOH resources, patients assistance programs to make sure they can get medication. And, these are things that are administratively burdensome for a practice that we can offload from them and handle those things and make sure that, the patient is getting the best care possible.
Well, that's super. And congratulations on being already a year in on this new program. What can you tell us about any early results after a year of implementation, and really appreciate the kind of support that you're providing for practices?
No, absolutely. And so I will caveat this. I always caveat to say that these are not claims-based metrics, but we utilize our ADT feeds, right? Because we need to have that post-utilization follow-up in place to make sure these patients are transitioning back successfully to the ambulatory setting. And so we're seeing very promising results on our inpatient utilization and our ED utilization. When I talk to my teams all the time, I would much rather be proactive and keep a patient out of the hospital than have to worry about a readmission. So how can we get ahead of that? When a patient goes to the hospital, they never quite get back to that baseline that they initially went into the hospital. And so when a patient's utilizing 6-10 times a year, it tends to be a downward trend for those patients. And that's what we want to avoid and put a stopper in place to make sure that, hey, we get this under control right now versus it continuing to escalate where they lose their independence over time. I think we all want our Medicare patients to be as independent, do the things that they want to do. Most of them work their whole life. They've earned this retirement. We want them to be able to enjoy it. And so being able to get ahead of those things, be truly proactive with their care, make sure they're managing their conditions appropriately, I think has shown those returns. And Dr. Lofton talked about, being an ACO model. We built this in conjunction, knowing that our practices, so we offer, risk-based contracts, value-based overlays for our practices, and ACO offerings. And so we want to make sure that we're not adding a payment, we're truly reducing the overall cost of care so that not only are they getting upfront payments through a fee-for-service reimbursement, but they're going to perform better in their shared savings contracts. And so, every utilization prevention not only is clinically significant for a patient, but financially significant for our practices when it comes to those shared savings opportunities down the road. And so on the inpatient side, we're seeing pretty, double-digit reductions right now in our inpatient utilization. Based off our ADT feeds, we're trending about 30% inpatient reductions at the moment. On the ED side, we're still working on that and modifying our workflows. We're seeing about over 10%, about a 13% reduction as of our most recent data on our ED utilization reduction. So we feel that's pretty significant. And my team and I look at these constantly. We evaluate the notes, we evaluate the clinical interventions to try to make that even more impactful for our patients. And so early results are promising. We're continuing to trend and track and make sure everything matches up based off of claims, everything else. But excited to see the movement that we've seen so far.
Absolutely. Because, I don't think any Medicare beneficiary wants to go to the ED or wants to go to the hospital. If they can remain in their home and avoid that kind of care and be, healthy enough to carry on, I think that is a shared outcome for the beneficiary, for the Medicare program, for the primary care clinician. Any researchers that are tuning in, I would encourage you to perhaps consider North Carolina as a place to go and look at the claims data and get a better understanding of how APCM adoption may be affecting utilization. These are the kinds of things that we want to be documenting and getting further insight into. So just a plea, somebody who's listening in here today, Sam may be knocking on your door, but appreciate that you're getting that data from the hospital through these feeds. And what I also heard you say is that in addition to APCM being adopted by original Medicare, you also see Medicare Advantage plans adopting this. Can you say a little bit more about that?
Yeah, so Medicare Advantage, with the exception of one plan currently, which is not supporting these codes or CCM codes for that matter, seems to be cooperating pretty nicely with these codes. And again, I think from an incentive standpoint, from a Medicare Advantage perspective, right? While there's an upfront payment and cost associated with these codes, if we are saving money by the reduction in utilization, I think there's a good incentive for them to encourage patients to participate in these types of programs, especially through the PCP. I know a lot of the Medicare Advantage plans will have ancillary support for patients as well. But it's not the same as working with your primary care provider. It's not going to be as holistic. It's not going to have the history that they have with their PCP. And that is just so important when it comes to actually being effective in managing patient care. And so that's where we work directly under that supervision. We're embedded in workflows. We're just an extension of the PCP, providing that support. And we have found that is really the difference maker when it comes to being effective with these patients, routing everything back and getting that big picture view that the PCP has as a cornerstone of that patient's care.
Well, I'm sure others, the other panelists want to comment, but I just have one quick question for you. Are you aware of any commercial payers adopting APCM in North Carolina?
Not as of right now. I know we're having some conversations around how we, fund programs like this across other commercial payers as well, and so those are active and ongoing conversations. So hopefully those will continue. Of course, I will absolutely pitch and speak to the importance of these services across all ages and all payers. I think there's going to be benefit, but more to come hopefully on that piece as well.
Sure.
May I
Others
ask
want to
a
jump
question?
in? Yeah,
Oh,
please,
yeah.
please. Yeah.
I've been curious about the cost sharing arrangements for Medicare Advantage and then there's in original Medicare and those with or without supplemental coverage. Because Medicare Advantage plans can make some adjustments. They have to cover what's covered in parts A and B, but there's some adjustments they can do to cost sharing. So I was wondering, in your experience, working with Medicare Advantage plans and the APCM codes, is there cost sharing for patients the same? How are they arranging that?
Yeah, so versus a cost share structure, it's a copay structure with most Medicare.
So they are imposing the cost. Okay.
There can be. Yep.
And it's about the same. You find it similar to?
Typically we see if there is a copay around $10. Now there's a couple plans in North Carolina. Now I can't speak to other states, but in North Carolina that across the board we have not seen any sort of cost share associated with these codes.
From Medicare Advantage plans?
Medicare Advantage.
Okay.
Yep. And so it just depends on the plan. And of course,
Right.
if they're a qualified Medicare beneficiary, period, they'll get full cost share waivers.
Right. That's a whole nother piece
whole
to
nother
it.
ball game.
Right.
Yeah.
Okay.
But even for our non-QMB patients, like I said, a couple plans in particular across the board, zero copays, which is very nice to see and encourages those patients to enroll in the program. But we certainly do have plans that have copays associated with it. We try to be very proactive with that, and we will check payer portals before we ever even contact the patient as part of the informed consent process, just to make sure we can disclose any sort of cost share that may be associated, because we want that to be upfront with the patient. It's extremely important.
Thanks, Anne. I was very
absolutely.
curious. It ranges, and I wanted to see how it was. And then there's, of course, we're often talking about people with no supplemental coverage and the out-of-pocket costs there too. Okay, thank you.
No, absolutely. And I think, as we all know, it's complicated, right? And there are, different factors that come to bear depending upon what payer you're speaking about. Jason, anything to add here, or I'll go on to a next question?
No, just the same. I mean, I think most of my MA plans are paying, although, I don't see I'm not in a position like Dr. Hyde is to oversee everything. I have a billing team that sends those out. And the dual eligible or the QMB patients, and they don't have any, that's nice that they don't have any cost sharing. And those do reimburse at a slightly higher rate, just for people that aren't aware of this. Probably double the rate of almost double the rate of what the lower two levels. And then I know I'd mentioned, I did see a question of the TCM, transitional care management visits. Those are when we have a patient inpatient come back to outpatient. We bill those and not the APCM, but the APCM is quite a bit less than what the TCM costs are. So somebody asked that, and I just wanted to clarify if they didn't understand what I was talking about.
Sure. I'm going to now ask you a question about if Jake was still with us, what would you tell him that would further adoption of this program? But before you answer that question, I just want to make sure everybody understands, and I'm going to look to you, Sam, to explain it. What are the different levels within APCM, and just clarifying what the practice receives as a result of participating in this program.
Yeah, and this was a big change with APCM that Jake, talked about, and you discussed with him earlier. So there's 3 different levels of codes, and it really simplifies it compared to historic CCM billing, which was time-based, had a lot of administrative burden associated just with that component of the program. So 3 levels of codes, starting at the lowest level, which opens up additional patients. So patients with up to 1 chronic condition can now participate with this program. It is reimbursed at the lowest level. That's G0556 for those of you listening.
And how much is that?
So that started at $15, although 2026 we did see a regional adjustment upwards on all 3 codes, so it's reimbursing slightly higher. I don't have the exact new number off the top of my head, but
sure.
$15 per member per month on that code. So it's a monthly billing cycle as a suite of services that's available and offered to the patient. G0557 are your historic CCM patients. So those are patients with 2 or more chronic conditions. That reimburses at $50 was the 2025 fee schedule rate per month. And then G0558 are for patients with 2 or more chronic conditions that are also qualified Medicare beneficiaries. So they have a low income subsidy through CMS. And so those patients tend to have a lot more SDOH concerns, a lot more resource requirements in managing their care. And so that was reimbursed at $110 in 2025. And like I said, all 3 codes did see a slight increase for 2026 in reimbursement. So, I think for me, and I'll comment just briefly on this, I think coming from the ACO world and value-based care, I really liked the shift in the model, and that it allows us to bring the right resources to the right patient at the right time and not have to, if I just need to do a 5-minute blood pressure check with a patient, I can do that. I don't need to spend 20 minutes on the phone just to meet a billing threshold. But if I need to spend 4 or 5, 6 hours post-utilization to make sure a patient's fully tucked in and that they're not going to go back to the hospital for the same thing that they just left for, I can spend that time because I can kind of adjust across my population as needed. So I think it's just much more effective as we evolve the model of care over time to be able to deliver the right resources at the right time.
Thank you very much.
Mhm.
Okay, so back to the question. If Jake was here in the room, what would you ask him to change or to even lean into more to further adoption of this code? And then we'll open it up for questions from the audience. There's a lot of them, and they're really good.
I mean, we've already talked about the cost share. That's my number
Yep.
1.
Yeah.
I don't know. I mean, that's the biggest hiccup for me. I think somebody had mentioned the consent. I mean, the consent's there, I think, as a Met Guard to a measure to try to keep people from signing up, people who don't understand it or agree to it. But that can create a little bit of a barrier when you're trying to get, some people are just hard to get a hold of. But I get the reason why the consent's there. I mean, you know, you need that.
Yeah, I think that my biggest gripe, I'll agree, is the cost share that just prevents patients from getting the services that could otherwise use these services. So, I think I would definitely lean into the longitudinal chronic condition component. I think it's very well, well thought out and well accounted for in the program. But anything we can do to be proactive with a patient's care, I think, is going to benefit patients across the board. So I don't have any specific recommendations in that area, but as you design your model out there, like definitely focus it on those chronic condition management components of it, and just make sure you have a good plan for that.
Thanks so much. Christina.
Well, my thoughts were certainly to consider out-of-pocket costs for patients and think about to what extent these are considered preventive and other mechanisms. So I would lean in on that and to consider and see how the performance is. I think Sam talked about a lot of successes, and so I think understanding what's driving those declines, what parts of it, so that we can learn from this across the country. I think there's another consideration about what this means for practices that aren't as large. Are they able to deliver the same pieces of care, how in sort of when they're not affiliated with a hospital, or I don't even know if your practices are, how independent your practices are, but so I think thinking about, making sure two things, that the services are really being delivered, that the value is being demonstrated, and sort of what we can learn from it to move on.
Thank you. Okay, now I'm going to turn to some questions from the audience. The first one actually is for you, Jason. You talked about how the APCM enabled you to extend your care team and supported you as the physician after hours and on weekends. So can you unpack that a little bit and describe how that is? And it does seem like you're very available. And so how does that not result in burnout? So I'd love to hear a little more.
Yeah. So, I mean, my patients, I felt like probably still maybe underutilized after hours, availability. I mean, so the way I see it's working, I mean, I can remember last year, I'm a cyclist. I was on a 50-mile bike ride one day, and I see a message come across from a patient needing a refill or needing something. I stopped on my phone. I used an EMR called Elation, and I'm able to send a medicine in right there. So things like that, those are kind of sometimes unmeasurables. Did we head off an ER visit? Potentially you can't measure. You don't know what it would have resulted in. But I'm traveling at times. If I see my messages pop across, I try to take care of them right then. And it works well. The patients seem to like that. They're surprised sometimes that it's actually me answering it, and my staff can answer. It results in quicker responses. So because if we're on hold, say for a prior authorization that's taken an hour to an hour and a half, there's a whole bunch of phone calls that aren't getting answered. But through our system now, we really encourage patients to use the messaging system. So while my staff's on hold, they're, whether it be doing a refill or sending me a question that I try to answer in between patients. So it's allowed us to get, I think, quicker response time to patients.
Super. We've got a question here about CAHPS and patient satisfaction surveys, and if there's been any movement in the CAHPS scores as a result of this program. And maybe Sam, since he's got a year in, might have looked at this.
I've not seen the 25 CAHPS data yet, so I don't know, and I think that'll be fairly diluted across patients participating in APCM versus patients not participating in APCM. So, we are excited to see what our ACO partnership CAHPS score looks like. But I don't have any data, yay or nay. I have anecdotal data of good stories that I see, delivered from my teams on a regular basis. But yeah, I'd like to see that supporting data saying that patients are more satisfied with their care based off of these services.
Yeah, I haven't seen scores yet either. I do know I had a patient recently that got upset that they couldn't speak to me directly. I realized we need to make sure we understand, maybe instruct patients better that by having the service, it doesn't guarantee they get to have me on the phone whenever they want. Because I'm seeing patients during the day, and they called in the middle of the day when I see patients upset that they couldn't speak with me directly right that moment. And so it made me realize we need to make sure we're educating patients on what they're getting out of this.
Sure. Can either of you, and Christina, please weigh in as well, talk about enrollment strategies for patients, because you do need to get their permission to enter into this program. And how do what's been a successful way to position this program for patients, and how have they responded?
For me, we tried to get everybody. So my Medicare Advantage wellness visits are front loaded at the beginning of the year, and so my January and February and March are heavily weighted AWVs, and so we implemented our strategy to onboard people during those wellness visits. And then for the ones that weren't going to be seen until later that year, we did make phone calls. And we're a small community. Our patients know us well. And it was fairly easy. I could see if you're in a more metropolitan area, maybe the patients don't know you as well. Or if you have a large system where some random person they don't know is calling, I could see that being more difficult to onboard patients. But our team is small, and so our patients pretty much know everybody on our team, and so I think it's easier for a small practice from a relationship standpoint. But there's the time strain with that as well.
Yeah,
Anybody else want to jump in? Go ahead, Sam.
I was going to say for us, we work directly with the primary care offices to get referrals for patients, but we have a dedicated scheduling team that goes through that informed consent process. So again, we're trying to offset any additional work from the practices that we can. And so, after a patient's identified by the provider or through our identification based off of risk stratification and other metrics that we look at, our team reaches out to the patient, explains the program. It's an opt-in program, so they are welcome to decline. But we lay out the benefits of the program with our care team model and the extra resources that they'll have with the dedicated points of contact. So we have a team that's dedicated to that outreach, and so we've been pretty successful with that and getting patients enrolled or getting patients routed back to their PCP that maybe haven't been seen for a while so that they can enroll in the program and get reestablished.
Well, thank you. Please join me in thanking these fabulous panelists for a conversation that can seem arcane, but really I think this code is really intended to help strengthen the relationship between a beneficiary and a clinician, providing the resources to give folks more time to do some of that basic but absolutely essential care coordination and communication that often either was undervalued or not paid for at all. So it's been a delight to have this conversation. We're going to continue to do work in this area. And as you heard Jake say, they want to build on this code as they think about how to shift our healthcare system to better support health and wellness. So before we close, ask everybody if they will fill out the survey. You'll get it immediately after this webinar. And we also have an upcoming webinar in May focused on trust and the importance of the primary care relationship in addressing what is rising mistrust in our healthcare system. Primary care is an essential place to really help address these issues and to support patients. So thanks for joining us. I look forward to seeing you next month. And please fill out those surveys and send a link of this webinar to your friends and colleagues. Bye now.